Welcome to Good Health Matters, where my goal is to explore how we can become the healthiest versions of ourselves. Today, I'm excited to speak to Dr. Conn, who is a triple board certified physician in neurology, interventional pain, and headache medicine. She's extremely passionate about what she does and has dedicated her career to helping patients have a better quality of life. This episode will cover things like how chronic pain develops and who's most at risk, headaches and interventional pain procedures, and the lifestyle habits that can improve your brain health. Before we get started, if you could take a moment to subscribe, that would go such a long way in this content reaching more people. All know what pain feels like, but from your perspective, can you explain what is the medical definition of pain and kind of how it's processed?
Yeah, so pain, we've all had pain if we're alive. And, it's interesting to try to define it. So the traditional definition is it's an unpleasant sensory and emotional experience associated with tissue injury or potential tissue injury.
Okay.
Yeah, because a lot of the pathways involved in pain are involved in emotional processing, which is important because it's a complete experience. It's a whole body mind experience of pain.
For sure. So it would start in the body, but ultimately the sensation is created by the brain.
Well, the brain is involved because, of course, when people are in coma, they don't have pain, right?
Yeah.
The things we do during the coma to stimulate the person, right? So we have to be, the brain has to be online, so to speak, for us to have pain, but the brain can become involved in the pain itself. Okay, like a good example of that would be phantom limb, right? The person's totally well adjusted. They know that their leg has been amputated. Okay, so there's nothing, they don't have any kind of underlying psychiatric issue, and phantom limb is quite common, and they're like, yeah, my leg hurts. I understand it's not there. And that is sustained in the brain, that particular type of pain. Yeah.
For sure. And then why is it that two people can experience the same type of injury, same event, but still experience a completely different level of pain or have a different pain experience?
That's a great question. And it's such an important question because we need to honor the difference is absolutely real. And this is one of the things that can bring up stigma, okay? Because sometimes people, family members, even medical professionals have trouble or accepting the difference between the way people are experiencing things. So what are some of the reasons people have such different experiences with very similar pain generators? Well, there's many factors. Okay, so we have ideas about pain from our childhood, painful things that have happened to us, painful things that we have cultural beliefs. Some people believe they're taught that pain is some kind of punishment. Okay, so there's all these belief systems before anything ever happens to someone. Okay, and then how we were comforted or not comforted as a child, like we all are going to fall down and skin our knee. Like what were we told as little people about pains and how to, okay, so these are some that go into it. Okay, so there's all these belief systems before somebody even has pain. But then and that changes our biology. So it's in dialogue with the nation. So everything that happens to us changes our brain, just like what we eat changes our gut, what we believe, what we see, what we've experienced changes our brain, right? Okay, and then if a painful and we're already, say, really upset, something very difficult happened that day, we had a car wreck, say. So our nervous system is already working, we would call it upregulated, okay? And then if a painful event happens, the nervous system is already, the volume is turned up, right?
Okay.
And so it will be experienced as more painful. So emotional and the regular before an event. So a big one is more than one pain generator. right? So let's say somebody had a broken arm already and then they fell and hurt their knee. Well, both things are going to hurt more because the common denominator is the pain. I mean, the brain, both the pain signals or go to the brain and the volume just keeps on getting turned up. So those are some of the basic way to think about the difference in pain perception in each individual, and it needs to be honored. It's absolutely real. Yeah.
Absolutely. Yeah, I think it's
Mm-hmm.
really important that you bring some of these things up. And kind of on that note, we know that women tend to experience more chronic pain.
Mm-hmm.
Um, why is that? Is it just kind of the hormones, or does some of it have to do with sort of historical,
Mm-hmm.
kind of like underestimating their pain
Mm-hmm.
severity?
There's a lot in that question. Um, so we know that women are undertreated for their pain.
Yeah.
Okay. And in particular, women physicians report it accurately that their pain wasn't treated. It actually happened to me
Oh,
after
wow.
a major abdominal surgery. I had no scheduled narcotics. Okay,
Oh, no.
it's a two-way street again because women's pain, we understand from studies, isn't treated as effectively and aggressively. And then do women have more pain? Yeah, this goes back to what I've already talked about. There's conditioning about like men are conditioned to be very stoic in general. It's, things are some cliche reason because the societal factors that drive them. And so, men are conditioned to be more stoic and in general, physically, women are not. And so those are some of the baseline stuff that we come in with when we experience pain. And yeah, our nervous systems are different. Um, and there's hormonal differences, and hormones affect pain. Okay, for example, with women, think of the time a woman needs the most pain tolerance. That would be during childbirth, right? And the
Yeah.
hormones like estrogen, progesterone, they're sky high. And actually, that pain. Okay, those really high hormone levels at birth have actions in the brain that decrease pain during a critical time. So fluctuations of hormone change pain. And we have new studies showing us that when women go into menopause,
Okay.
that they have all this pain, a group of them, because the pain regulation they were enjoying from their hormones is, and that's yet another that most women benefit from hormone replacement therapy. Yeah.
So we've kind of talked about pain. Do you mind explaining kind of like what changes when like acute pain becomes more chronic pain?
Yeah. So that's a great question. And it's a fascinating question. Okay. So there are predictive factors when some people have chronic pain. Okay. Unfortunately, most of us have acute pain and we accommodate it and it goes away. But what we do interesting is that even when we have a very small pain, like say we hit our finger with a hammer. Oh, that hurts. It's real. And when we look at functional MRI, what's happening in the brain, even when we report, oh, my thumb is better, the
Yeah.
brain have not calmed down yet. Okay, so the brain, when the brain has breaks and it's modulating and decreasing pain, right? And going back to that baseline equilibrium. Okay, so there are central things doesn't settle. But there are predictive factors when, like post surgery, if people are having very difficult time getting pain control right after a surgery, the first 2-3 days, that group is more likely to have chronic pain. People that have endured childhood abuse are more likely endure chronic pain. People with a family member with chronic pain are more likely to, and that probably is genetic, but it also is in a household where they witness this. It affects us, right? Everything we see, like I said before. So And that's a partial answer to your question.
Yeah,
Yeah.
people can still be suffering from like real pain,
Yeah,
even though we may not be able to see things on
right.
imaging or labs. Is there like, are there still real changes that are happening in the brain in terms of like rewiring that happens with chronic pain?
Right. So you touch on something again, very
Yeah.
part of what drives stigma. So when somebody has a one can see it. We can all look at the x-ray and we're like, oh, broken arm. And it was certain types of pain I treat, like herniated discs. We can all look at the MRI and we're like, oh, see that. We can all, people feel mirrored and seen when you can, it's very concrete. Okay, but not everything is very concrete. Okay, we can't see it. Like fibromyalgia type pain, which is all over, body aches and pain. And most pain we actually can't see. Functional MRI,
Mhm.
something that we have available to us on it for it helps so understand what the patients are going through, but we can't apply it to an individual patient. Okay, so I mean, I believe the patients, they are about their discomfort.
Mhm.
Okay. And so then it's up to us to try to understand what's driving the discomfort. So yeah, diagnosing chronic pain it can be challenging, but the brain, it rewires neuroplasticity. So the earlier we get to the person in that transitional period, the easier it is to switch the brain back.
Mhm.
Doesn't receive treatment, the heart would be like, if you think of the Pledge of Allegiance, I pledge allegiance to the flag. Most of us just said the next line in our head because we've known this since childhood. It's over memorized, so to speak,
Okay.
the Pledge of Allegiance. And unfortunately, that can happen with pain. It's just difficult to forget it. But there are ways to help us forget it and remodel it. And that I just want to bring here, and that's cognitive behavioral therapy, which is a critical treatment for pain that is underutilized, not off a lot of reasons that it's not highly, highly effective. Yeah.
Like that you keep bringing this idea up of like stigma with chronic pain. So I've definitely seen some of the studies out there with not just healthcare providers, but even people out in the community where they have them watch videos of people in pain. And they actually find that there's kind of negative judgment about people that show facial expressions of pain.
Yeah.
There's sometimes not a lot of sympathy, things like
Mhm.
that. So I think there's definitely a lot that needs to change about the culture of like how we see pain just as a community as well.
Yes, it would be more supportive for patients if there was less stigma and for their families because the stigma affects the family and the friends too. And are vulnerable. And
Mm.
any of us can have a pain problem under certain circumstances that we can't control.
So opioids have, become part of the conversation for a long
Mhm.
time now. What do you
Yeah,
think about how do you balance the benefits that they have versus some of the safety and risks?
it's a very complex question. Okay, I was, cut my teeth as a doctor whenever the drug companies were trying to make that opioids were not. And so I've personally seen the entire cycle happen, right? And the heroin epidemic that I mean, I trained at a safety net inner city hospital, and I thought I would never see that again, and I was wrong.
Okay.
Um, so this is a huge societal problem and a deeply personal problem in families. I see in a disorder comes up with their family, deaths of family members. So very, very rich question.
Yeah.
So what opioids are good for is tissue injury pain. They're really great for that. Okay, you have a surgery, like when tissue is injured, opioids are very helpful. Okay, for nerve pain, opioids really are not helpful. Okay, they just don't work. We need
Okay.
to use our nerve pain medicines, right? Like our first line medicines, gabapentin, and that's when interventional pain is very helpful with the nervous system do nerve blocks. I do a lot of spinal cord stimulation, right? I'm modulating, I'm talking to the spinal cord, and just like as a pacemaker, you talk to the heart in electricity. Okay, so there are time for opioids during the acute pain phase. It's okay, but in the chronic pain phase, there's actually no studies to support the use of opioids in the chronic pain phase, which is actually shocking. Most people don't know that, and what our society and so many of us are without one study to support pain. So chronic pain need very rich multimodal treatment involving a lot of some of the things I've touched on, but other things I haven't touched. So opioids need to be used with care, pain on a case-by-case basis, individual's desire, the family history, the individual's personal experience. So this needs to be explored with the person we give opioids. Like, we need a plan to get off them, right?
Mm-hmm.
Because they change the nervous system and they can even make pain with something we call central. They can change the brain in a way that makes pain worse.
Okay.
So that's really important. Yeah, there's a lot in that question. Mm-hmm.
Okay, sounds good. Yeah, thanks for answering that. And I definitely want to go back to interventional medicine and kind of all of the
Mm-hmm.
different procedures that
Mm-hmm.
are performed within that space. But first, I wanted to ask you about headaches. Many of us deal with headaches occasionally, but
Mm-hmm.
what is it, if you had to say, that differentiates a regular headache from something that, people need to see a neurologist for?
Yeah, that's a great question. So there's two categories, the emergency headaches, and then the headaches are very difficult, but they're not emergencies. So if somebody experiences that thunderclap headache, the worst headache of your life, that's an emergency room headache. They are starting to get sleepy, they have fever, a stiff neck, like unable to move some part of their body. Those are emergency headaches. Then people need to go to the emergency room. So that's the first category, for the emergency headaches. Then there's the headaches that are very terrible and difficult, but they're not emergency room visits. Okay. It is defined as 15 headache days, more than 15 headache days a month for more than 4 hours. So that definitely needs neurological care, because to endure, not good for the brain. Headache is ultimately not good for the brain. And once somebody gets into that chronic headache cycle, the majority of them need help medically or with interventional procedures to improve and get out of that chronic cycle. Then the other category is people that have like migraine type attacks. I have, so they're not in a month, but they have attacks that are temporarily disabling and difficult. And of course, they need treatment, but that's not, they in general need it from, to start with the primary care, try to get in. Unfortunately, there's not. And occasionally, those people do go to the emergency room because their acute attack is so terrible. And that's not wrong, because tell between an acute migraine and dangerous headaches I described. Yeah.
For sure. So you're saying that kind of the thunderclap headache, it's really differentiated by the sudden onset versus something.
Of my life, that's what people say.
Okay.
I mean, they're agitated. A lot of times they can't even move.
Mm.
Okay, they're truly miserable. And yeah, that needs to go to the emergency room. Yeah.
Okay. And thanks for
Mhm.
kind of breaking that down into kind of the warning signs, emergency signs of headache versus, something that still needs to be seen versus, maybe not as emergent. Came across this kind of condition that's linked to overusing, kind of like over-the-counter pain relievers. Could you kind of go into that and what causes
Thank you for that
that?
question. Okay, what you're talking about is medication overuse headache. This is incredible, and it's incredibly common. People do not know about this and they're not told. So for us in the South, it's usually BC powder and Excedrin migraine. So people are taking that like every day. And a lot of times patients won't volunteer that because they don't think of it as medicine because it's over the counter. So they need to be directly asked about their over the counter medication uses. So when rescue drugs, like there's, except for migraines, actually perfectly fine if you take it rarely.
Mm.
But if taken more than once or twice a week, it could convert these discrete attacks, and the person truly has no idea this is what has happened, and their migraine is being transformed with medicines and get diagnosed, and they have no idea. So you really have to dig in with them to understand what's happening. And then it's really difficult. They are afraid to stop it.
Mm.
Okay, they're so afraid, but there's no pleasure. The addiction, like they're so afraid, they seek it out, they don't want to be without it. But of course, there's not like, addiction has euphorogenia, meaning it makes people get high. There's none of that, but yet it has that quality. So they're really afraid to get off. So the way to support the person is first to educate them and then to get a good prevention medicine and then slow them wean the drug once and then give them a rescue medicine, a stopper medicine that won't cause medication overuse headache. So that's the process. And I'm so glad you brought that up because it's missed all the time. People have no idea that this is what's going on for them.
Things that people can try to do at home. So you commonly see things like using a cold pack, heat, magnesium supplements, I've heard, but things like that. Like, how effective are those, and which things kind of like don't have evidence behind them?
Yeah. So, of course, some people don't want to take medicine. That's to be respected. So, migraine, first, the big thing is understand your triggers.
Okay.
Everybody has triggers. Some people find their triggers for a number of reasons, but if triggers, avoid your triggers, which sounds so simple, but there's all these lists on the internet of things to avoid. And what I like to say is don't avoid other people's triggers, just avoid your trigger.
Yeah, that's a
So
good point.
understand, try to avoid them. That's the first thing. Um, the migraine brain in general likes steady state. It likes it when things don't. So that helps understand patients. So eat regular meals. Missing meals is a huge trigger. So bring like a snack in your pocket or whatever. That's important because that's a huge trigger.
Mm-hmm.
Go to bed at the same time every night, get up at the same time every morning, even on weekends. Okay. And exercise, eat regularly, sleep. Missing sleep is a big one. So these are the lifestyle and to keep steady state. It's a lot. Hydrating, staying hydrated, because again, that's another common trigger. Sleep is a really good way to reset the brain. As for supplements, magnesium does have evidence. Okay, magnesium's good. Factor is often diarrhea. Enough magnesium that it's helping them, they have diarrhea. So that's individualized. The person just has to see if they can take enough to help them and how they individually. Other things that have evidence those are supplements. Those are over the counter. People ask me the dose. That's tricky because these things aren't regulated. So I recommend getting one brand and sticking to that brand and getting a dose that works for you. And you're more likely to be getting the same dose every time. At home management, that's triggers and lifestyle things that can help. And then meditation, mindfulness. I didn't tell you about this. Mindfulness meditation helps, and eating the Mediterranean diet over months decreases. And then, of course, balance, meaning got to keep your thyroid straight. All the other general medical things, go to the doctor, make sure there's no anemia, no thyroid problems, all that there's no illness driving things.
Awesome. And, with things like meditation or exercise, so like a certain time length or
Mhm.
type of meditation, things like that.
Yeah, that's a great question. Okay, so there's a new subspecialty in neurology called neurology. Okay, and the specialty around dementia, trying to prevent or reverse dementia, which is really important because of our aging population. And my dad has dementia right now, and so it's very difficult. Solving in the field is Richard Isaacson. So if you think about what's one of the most difficult neurological conditions to reverse, it would be dementia. Okay, so he did these wonderful studies about lifestyle changes, really rigorous studies showing what helps. And so the recommendation is actually 150 minutes of exercise a week. Actually, that is one of the things we can do for the brain above anything. It's exercise. It's aerobic exercise. So I endorse yoga. I do yoga. I endorse working in the yard. It's all good. That changes things and it helps the brain. It releases growth factors called brain-derived neurotrophic growth factor. So it actually helps the brain be more healthy. So exercise is key. And part of the study is about meditation. And in the study where they showed reversal of memory loss, the dose of meditation was 1 hour per day. So that's a lot. I'm actually not sure which technique they used. And that is a complex question because different people need to do techniques depending on how they're built, right? Like some people need to do walking meditation, for example. If they have ADD, they just can't sit down. It's real. So they need to do walking meditation. So we need to translate this for the constitution of each individual. But these landmark studies, it was an hour of meditation a day.
Oh, yeah, I meditate, but it was something when I first started that it was only like 5 minutes. Definitely something to work on.
Yeah, I'm so glad you said that because here it's studies. The great news is 5 minutes a day makes a big difference. Brain is actually altered by 5. So that's encouraging. Skills to develop, like learning how to play golf, just start. And so doing these small little things of meditation are profoundly beneficial. Yeah.
Going back to kind of the interventional pain concept, can you walk me through what is it like as a specialty for like interventional pain and what procedures are part of that? I know you mentioned kind of nerve blocks, but
yeah. So for me, it's a great specialty because it combines being in clinic and then doing procedures. So I like the diversity of both environments, but also in interventional pain, there's types of procedures we can do, which is fun. The variety is really fun and it keeps me interested. And the field is really a big field because we're getting new therapies. When I first went into the field 25 years ago, there were 9% women. Now we're up to 18% women. And we have, women innovators in pain medicine, and we don't understand why more to it because we all love it. So I think there's not enough exposure in medical school. People don't know what it is. Yeah, I do a varied types of procedures and spinal cord stimulation. What makes me different than most of my colleagues is I do interventional headache. So I do a lot of things in the head that I combine with to treat headache. Like stim skin in the back of the head, nerve in the back of the head called the greater occipital nerve. And so we pace that nerve and it stops this headache loop. Okay, there's a really common headache. Had the nerves in the face and the brain stem, and it's hamster wheel, and we try to hamster wheel and slow it down. And I'll do that with medicines and procedures in combination. So I can stimulate a peripheral nerve almost anywhere in the body. Like when people have a nerve in their shoulder, in their knee, I'll burn the nerves around the knee, do blocks all over. I'll put spacers between the bones and the spine to like open up the space a little bit. I'll do small fracture repairs. I do a good bit of pelvic. Okay, because men have more pelvic pain than men. And a lot of the women want to come to female doctors for that. And there's not that interventional pain. And yeah, I see a lot of those patients and I'm happy to. And so then I'll do blocks in the pelvic floor, Sometimes I'll do spinal cord stimulation, but I'll put it into the pelvis for that.
Some headaches that are like better suited for procedures than others. Would you mind kind of like explaining which ones these
Yeah,
procedures would be?
ergogenic headaches are very dangerous. And for once, our word actually describes something, because sometimes our words in medicine are not, they're not descriptive of the illness. So neck makes the headache, cervicogenic headache, cervical spine generates headache, right? So who has that? We all get the privilege to live. We have usually get some arthritis in a lot of places in our body and in our spine and in our neck. It's in the neck. They're called, they're a lot like they have fluid in them. And so as we age, you see people's fingers get larger. Well, that's happening in the spine. Okay. And the nerves that go up the back of the head are formed there. And so then we want to make those nerves, so to speak. So it's with also with trauma. If somebody has a trauma and they're young and they've had a big neck surgery, they can get that cervicogenic headache. So those types of headaches are particularly good for this. But the other group is really people don't have a neck problem, but they have just such a severe headache problem. I'm trying to get in that loop I described to you, the hamster wheel loop, and we're just trying to access that loop. And sometimes I'll do it from the front of the face too. I'll go and do the trigeminal nerve. I'll do it with the ear. Sometimes I'll put things I can do. We go up the nose and do a block up the nose. Sometimes I'll do certain blocks on the face and little. But one of the big ways is a whole different way to get into the system is with vagus nerve stimulation. That's underused. We can stimulate the vagus nerve with extra, and it's indicated prevention and rescue. And it's underused because the only group that has insurance for that are the veterans. Of course, we're thrilled that they have that because of the amount of traumatic brain injury and pain after concussion that this group endures. But other people, the rest of the population, does not have coverage. And therefore, for many complex reasons, most patients are not offered the vagus nerve stimulation device. And that's something I emphasize and I use for my own migraine.
How effective the vagus nerve stimulation is? Like, does it take several months to kind of like see the effect, or is it something that you can see?
So it's rescue and prevention. Okay, so the rescue, it works well. Attack prevention take up because again, it's the volume, you're modulating it, you're turning the volume on the stereo in the brain, and it's not instant gratification. You turn the button and it takes a while for the brain to settle and change. So it does take a while to ramp up.
Yeah, thanks for sharing all of that. What would you say some proactive habits that people could do to really improve their brain health over the long time?
Most effective thing is exercise. That's the number one most important thing. And the goal dose, and I say goal, is 150 minutes a week of aerobic exercise. And everybody can exercise for where they are. Okay. As we age, we're not going to be jumping up and down. That's okay. I mean, so sometimes as people get older, they get orthopedic injuries. It's the stationary reclining bike, pool walking, elliptical. So we're going to change how we exercise on where our body is. We all need to find a way to exercise to improve our brain health. It's amazingly good for us. It's shockingly good for us. I mean, the newest studies, I've even been surprised of some of the stuff it does that is wonderful. Yeah.
And like you said, there's a lot of options. So everyone can find something that works for them. Any recommendations for sleep?
Right, undersleeping and oversleeping are both problematic. So recommendation is 6. Okay, but that is individualized to some extent. So I think some of the big things we see about sleep is what people don't know about what we call sleep hygiene. So sleep hygiene are the sleep habits. Okay, so if anybody that has a baby knows that you teach a baby or a young child to sleep, like you give them a bath, read them a book, tuck them in, kiss them, you do it at the same time. And the young child, well, that all applies for adults, for us too. Like we need to have bedtime habit. Night clothes on, time. Okay, so some of the common things are no watching TV in bed. That disrupts sleep. not sleeping with the TV or any darkness, because that changes there's centers of the brain and the hypothalamus, this deep brain center, that part of sleep is disturbed by lights. Okay, drinking a lot of water at night, drinking alcohol at night, taking naps. Okay, and if you can't sleep, it's best to get out of bed and just go sit in a recliner and do something not stimulating. So there's a lot of sleep hygiene, but it's very involved in the habit. There's also therapy for sleep. Okay, and so a caution, as many people have been put on pines. It's a sedative class of medicines for sleep. It is not good for the brain. It's associated with developing memory problems. And people, when we sleep, the brain goes through different things. Maybe you've heard on TV, slow wave sleep, non-slow wave sleep, REM sleep. Okay, so the brain's very active during sleep. And so when people take things like benzodiazepines or even Benadryl over the counter, all that is blunted. So they go unconscious, but they don't have restful sleep. The other big thing is make sure you go to the doctor if you're snoring, and if the bed partners or people in the house are like, man, we can hear you snoring. That's concerning and that needs attention.
For sure. Yeah, that's really helpful. As we end this episode, do you have a message or any advice that you want people watching to take away?
Protect your brain. Oneself. And this internal talk that we do with ourselves really affects our brain, because I've talked about it's a two-way conversation. So doing the things to support, like sleeping, but exercising, doing meditation, self, and just this is very important kind of self-care, because it changes the trajectory not only of one's own life, but our family and friends around us. Because when we have brain health problems, it affects everyone in our social circle, right? So when we take care of our brain, it's an act of self-care and self-love, but we're also actually serving the people around us and our loved ones, and we're serving the greater society, right? Because if our brain stays healthy, we're able to serve in society. And so it's not just about one's individual self, it's about the community and the world, and it really just ripples out. So it's a beautiful thing to bring benefit by caring for oneself in this way.
That's beautiful. Yeah. Thank you so much, Dr. Conn, again, for taking the time to be here. I learned a lot, and I think, everybody getting a chance to watch will take away a lot from all the tips you shared today.
Thank you.